So I farm so hard, the employees wanna find me, and then wanna hire me. What's 100K to a guy like me? Could you please remind me? Farm so hard, this ain't easy. Working late nights, you best believe me. My grades can only go ace. Never wanna see another B unless I'm Jay-Z. Farm so hard, let's get paid.
It's your host, Jimmy Pruitt, aka Pharm the ED, and I'm bringing you another episode of the Pharm So Hard podcast. I'm super excited to be continuing this EM pharmacotherapy review series where we're highlighting anyone who's an ED pharmacist that's published or anyone who's published in the EM pharmacotherapy space. And I'm super excited to have this episode actually join with the primary authors of this super, super cool study. And if you know anything about EM pharmacotherapy, you need to, if you want any research done, you go down to the Dub. You go down to Wichita, Kansas, and those guys have been pumping out stuff like a madman for the last probably 5 to 10 years. But I just want to go ahead and introduce one of the one of the authors of this study. And I got my friend BG as well in the background, but today is not about him. We're talking about Brock. So Brock, just tell him a little bit about yourself, where you're at currently, where you're from, and we'll jump into the study.
Hey, Jimmy. First of all, thanks for having me on. Really excited to be on today. So as I said, my name is Brock Townsend. Originally from Wichita, Kansas. Did my undergrad and pharmacy school at the University of Kansas, Rock Chalk. Then after that, I went back down to Wichita at Wesley Medical Center, did my PGY1, and now I'm currently doing my PGY2 in critical care here at Wesley as well.
Yeah, I'm super excited, man. Again, anytime I'm looking at the top-notch research, the critical care residents are always pumping out stuff there. Again, you got somebody that's on, but for someone who just happened to never, listen to our podcast or just really under a rock, BG, give them a quick little one-liner about you.
First of all, JP, I don't appreciate you calling me out saying I'm old, been here a decade. I mean, it's close, but not quite. I've been here at Wesley Medical Center about 8 years now, but I've been in emergency medicine services now for 7, 8, 9, 10, feels like 15 years after COVID. But happy to be here again. I can't remember how many times I've been on Pharm So Hard now, but it's getting up there. I'm starting to get that honorary guest status with you. I appreciate it.
Yeah, you got to think the very first episode we've ever done, and I think this is going to be close to like 120, but episode 1 was with BJ. So I think this is going to be something that's pretty cool. We've done a few more after that, but anytime we think about Pharm So Hard, you got to consider the work that BJ's done for our podcast, but really realistically, all for emergency medicine, critical care, I would say acute care pharmacotherapy. So that's what this series is about. But I really want to just jump into the study because I think people need to see this because we hear a lot of chatter about you got to immediately run, get your Kcentra, and slam it into the patient, or we're going to be in bad shape. So let's just go on talking to about the study. Brock, walk us into this study. Kind of tell us a little bit of background, and then get into the methods, and then we'll slam into the results and implications of this study.
Yeah, so in this study, we really wanted to look at the impact that time to administration of 4-factor PCC has on outcomes associated with warfarin-associated intracranial hemorrhage. So we know recently there's been a lot of focus on time to reversal agents for intracranial hemorrhage. If you look at the guidelines, several different guidelines that have commentary on it, and they recommend urgent reversal, or they recommend rapid reversal, but there's not really any definitive guidance on what they mean by that, or what the direct time to administration should be, which is in contrast to, some other guidelines like ischemic stroke, like STEMI, or like sepsis goals. And the urgent and reversal recommendations is really just based on low quality of evidence. So we really wanted to do with this study was to just try and get some more data, try and look at how the time to administration impacts the clinical outcomes. In this case, the clinical outcome being hemostasis achievement. So this was a retrospective observational study. We stratified patients in 3 time intervals, less than 45 minutes, 45 to 90 minutes, and then greater than 90 minutes. again, with the primary outcome of looking at rates of achieving effective hemostasis in each group. And we defined achieving hemostasis as a less than or 20% increase in hematoma volume. And that was based on the landmark trial done by Soroti and colleagues many years ago. Do you want me to go in?
We love a good time 2 study in medicine, whether it's acute ischemic stroke or sepsis or whatnot. So, there was more and more chatter coming out about, bundled care with ICH and, how long does it take me to get to my goal on this? And, there's going to be in the next 5 years in the guideline iterations, these goals, and the institutions that are handling these patients are going to end up being, kind of kept to these metrics and these goal times. So really the idea was, let's just look generically and see if there's any difference between patients that get reversed faster versus those that didn't, and that was sort of the idea and the goal. And, ultimately, one of the things that we were thinking of in the back of our head that Brock and I were talking about was our current process for PCC administration is that our PCC doses come from our main pharmacy. And so one of the things we wanted to ask ourselves was, well, shit, if there's a big difference in, hemostasis achievement with faster times, should we be putting those things in our automated dispensing cabinets and designing programs and operational, variances that will get the drug to the patient faster? And so that was our sort of back end goal on this, was to try to look at this and see, do we need to be stocking this and change our internal processes, which I know is having looked on, some of your Twitter polls and just, kind of talking to other clinicians out there, this has always been a question of whether or not, do PCCs come from your pharmacy or do they come from your automated dispensing cabinets? And so it's a process that's not as simple on paper as it seems. And so that was also in the back of our mind.
I think everyone wants to figure out whether or not we're going to do it and to what degree. It's like, and then as we start looking at the products and that nature, I think all the different types of PCCs that's out there now, whether you got the Reglex hinge, you got the blue tinge, looking at everything that's going on, kind of figuring out this question, because what I see happening down the road is that we may be required to do it by XYZ time. And if we're going to do that, let's make sure we're actually doing it based off some data. So I definitely commend you guys for answering an important question, not just for the bedside pharmacists, but looking at it from an institutional standpoint. Or we're going to end up in this sepsis world where if there's no data and there's one sensationalized trial that's out there, we're going to be giving case intro within 2 seconds of them getting into the hospital. So I think this was pretty cool. But as we look at this, what did you guys find? What was the big thing that you guys found, and how can this be implemented across the board for other pharmacists?
Yeah, so this study, we were only able to include 39 patients. There's a much larger patient population on factor Xa inhibitors than we anticipated, so low sample size. But between the 3 different groups, there was no difference in the primary outcome of rates of achieving hemostasis. Looking at secondary outcomes, including hospital mortality, hospital length of stay, and intensive care unit length of stay, and adverse effects like blood clots, there was also no significant differences. So ultimately in this study, there is no difference between any of the groups and the outcomes that we looked at. So when we look at
this, because sometimes people just need a straight go-to and figure it out. So given the study didn't find any significant difference in hematoma achievement across the different intervals, which is kind of big, no matter how you look at it, no matter what the sample size is going to be. Given that happened, what is the implications that you guys believe is going to happen for emergency medicine regarding the timing of 4-factor PCC administration? Because again, this is going to be a question that many administrators, and I think as people get into emergency medicine, and whether you're on these states and national organizations, there's going to be a lot of things that come out of this, and we're going to be saying, Brock found a study that said that there's no difference. So should we be doing all this? What are your implications for all of emergency medicine, critical care, and I would say hospital, pharmacy administration based off of this study?
Yeah, JP. So I think there's an interesting sort of dilemma, right? So first of all, we only had a small sample size, and so it's important to recognize that this may potentially not be powered enough to really find a difference. And so ultimately this was just a almost not a feasibility study, but almost just an exploration study to see what was going on. And so we wanted to evaluate again, if there was a difference, then we wanted to change practice right away. And so I really don't put much credence into us not finding a difference. So we just really were not sampled to find a difference. There recently was a larger study by Frontera and colleagues that evaluated this and actually did find some statistically different meaningful clinical outcomes that were associated with faster administration, which is to be expected. But as you said, it's one of those things that as an administrator, you want to make sure that the processes and operational changes that you're going to go through for your entire department is actually backed by data. And so I think this was just, again, a smaller study that, while we didn't find much difference, it's not not much that's going to alter what we already think in terms of time to administration for this process. We know that hematoma expansion is not a good thing in these patients. And so, it just still makes sense clinically to get these patients to a goal INR quicker rather than later.
Yeah, so if we look at the recent Code ICH position paper with recommendations, they have anticoagulation reversal within 60 minutes listed as a goal. All these organizations are going to be coming out with different recommendations, different times. We just need to try and ensure that those are evidence-based and providing the best care for patients moving forward.
Perfect. So I think a lot of this kind of gets us to the point to where many people are going to be saying, okay, guys, you guys did this great study. We have some implications of all of this. Realistically, the study mentioned some limitations that we want to make sure that people have, because if we don't mention it, they're going to kind of come after and say, "Yo, well, this was this kind of study." So again, we mentioned things like there are limitations like collecting baseline size and location of the bleeds and potential for inconsistent radiology interpretations. How might these factors affect the study conclusion, and how could the future research address them?
Yeah, so of course there are several limitations to the study. One of them being the sample size that we've already touched on. Another being that we didn't collect the baseline size or location of the bleed, and ultimately these can have some impact on outcomes. Depending on where the location of the bleed is, it could be more likely for the hematoma to expand even with timely reversal. Size and location also play a large part in mortality and length of stay outcomes, regardless of time to reversal potentially. So not collecting this baseline data really just introduced some confounders that, if we had collected, might have led us to identifying one of the reasons we didn't find a difference in this study. As far as listing radiologists, interpretations is a possible limitation. There's just always possibility with having numerous different radiologists interpreting these CT scans for there to be variability. So it's just a potential confounder. If you were able to design a prospective study looking at this, and you could be able to standardize how the radiologists either interpret the CT scans or at least report the CT scans, that would be nice, but obviously not really feasible in a retrospective setting unless you were to have an independent, few radiologists go back and look at all of the CT scans retrospectively. So that's just one of the possible limitations in this study.
Yeah, JP, there's software out there that you can utilize and for sure to make it more standardized and validated internally. But we're balling on a budget out here in Wichita. So we didn't have that kind of time with a resident research project, and we also didn't have that type of funding. But, Brock makes a good point that type of standardization is going to be needed to really assess that high quality RCT type level data. But just not something that we had that was feasible in the setting of, a year project. For the most part, though, we did discuss this with our radiology department. They try to keep it as close to standardization as possible. They do measurements, but it's not, again, it's not within a software that's also going to validate those measurements. And so It's fairly close, but in terms of having like a single reviewer, we didn't do that, and we were like I said, we were trying to maintain within the confines of a year's study for a resident. So if anyone's listening out there with funding for some of these AI softwares that can calculate this for us, first go ahead and sponsor Pharm So Hard, and then afterwards go ahead and sponsor myself. Hit me up with that grant money. You can find me on Cash App, BG Big Daddy. I'm just kidding, but no, for real, it's definitely something that we need, and would definitely make the study more valid. But it's a fair limitation. I think we address it, and I think we don't shy away from it.
Yeah, and I think that's one thing many people, try to do, and they write in their study like, "This was a perfect study. This was perfect, and we didn't have any limitations." Like, fam, come on. So my thing is, we always mention it up front so people can really have understanding. But more importantly, we mention it so that people who want to replicate this and do it again. This is it's a very important question, and I personally believe that we better answer it first before regulatory bodies answer it for us. So we really want to get this data out there to let us know. But I want to close out with my last question for you guys. And I think BG may like this one quite a bit, because we started this entire podcast based off of this similar question. So given the increasing use of factor Xa inhibitors and the limited data on clinical outcomes associated with the reversal, how would you see the future of a pharmacotherapy evolving in managing anticoagulation-related ICHs, particularly when looking at the question that you guys answered?
I'll take a little bit of this, and then I'll let Brian run with it. I think one of the important factors that we're going to have to look at in the future is really just the processes in place of getting these patients the medication, especially once we start having potentially multiple agents depending on your practice site. Like we have PCC. That's all we have at my institution. Some other institutions may also have andexanet alpha. So when you start having multiple players, you just really want to make sure that you have good processes in place to get patients the medications in a timely manner. And it's also just one piece of the puzzle, timely reversal. There really needs to be continued research on these other aspects of care, like blood pressure management and several others, to really just provide these patients the best care that we can.
What you got, BG?
Oh boy, we got another hour, or what we? We should revisit that pod. Brock did a great job. So ultimately, I think this is going to lead us down. I mean, it's going to be personalization of the protocol to the patient. So these, cookie cutter protocols, one size fits all. I mean, they're good for, that standard deviation. You're going to fit 75 to 90% of your patients in there, but ultimately you need to assess what's going on with the patient and try to identify those patient-specific factors that potentially could alter your outcomes, right? So for factor Xa inhibitors, we're starting to use these more and more in patients that are going to have protracted half-lives. So what does that mean in terms of PCC administration versus andexanet alpha administration versus other agents that are on the horizon potentially? And so, those type of things are going to weigh heavy on us. Bleed location obviously is going to be another important factor. And whether or not that's going to change which agent we use, I don't know, but potentially. And there's just so many of these personalized factors that really need to go into these decisions, and it's going to be very difficult with just a one size fits all get reversal to these patients by X amount of time. And so I think that for the most part, you have to treat patients on the highest level of acuity that there is possible and the most dramatic fashions possible. So, somebody with a deep lobar bleed that's going to have a high risk for expansion into ventricles and potentially have worse outcomes. Those are the type of patients that are going to be the highest acuity that you have to basically develop your protocols for, because there may be other patients that you may not hit the metric, but they're still going to do fine regardless. You may not use XYZ drug, but they're still going to do fine regardless. And so, Yeah, a lot. I've been really big on the personalized medicine approach for all indications here lately, and I think that this is another area that potentially could be highlighted. But yeah, no, we started with ICH just as low hanging fruit. We had a lot of those patient data points, and but it's almost a moot point with warfarin ICH nowadays because so many patients are on these direct oral anticoagulants, and who knows what will happen with these factor 11 and factor 12 inhibitors, but we'll see when that time comes and what that means. But yeah, no, this is just the tip of the iceberg. I really think we're heading down that road of having these time 2 studies and protocolize it for a positive way. I really hope that it ends up being a very positive thing as opposed to just some of the time 2 studies we have with sepsis where these governing bodies are dictating clinical practice more so than the data is.
Yeah, I completely agree. I think we're getting to the point to where I think a lot of pharmacists now are kind of transitioning in roles. So a lot of you guys have been putting out research. You guys have more leadership roles. And I think what happens is once we get to those points in our career, we start to realize that in order to have the best patient care, we have to change the things that we do. So you're a phenomenal bedside pharmacist, and it's great. And then you do the research, but then now this type of studies kind of transitions you guys. It transitions you from having data that's going to be important questions to answer to be able to put stuff like this in front of people that wears the suits, I like to say, and make some type of changes based off of that. So whether it's going to be this study or another study that comes that reference what you guys have done, I think this is something that is I call a snowball starter. So where we can figure out whether or not we need to focus on this particular question for this particular agent, or is this a question that needs to be answered in a broader sense? And what happens when you get 400 or 500 or 1,000 patients that use the same exact setting you guys did and expand it? So I think we're going to answer some great questions, but I want to highlight the beginning because what usually happens is you get the SPICE 3 study, you forget SPICE 1. You get, NINS 2, you forget the NINS 1. You get ECAS 3, you forget ECAS 1. So I think we need to understand and kind of highlight the beginning of these revolutions. And I think this is going to be one of those. And that's why I was really happy to highlight the work that you guys have done. And I'm pretty sure there's going to be a lot more work that's going to get pumped out of Wichita. So I thank you guys for coming on. Any closing words for the audience, Brock and Brian?
Yeah, I don't think I have any, Jimmy. I just really appreciate you letting me come on and talk about my study and really highlighting it. It's just exciting to be a part of it, so I appreciate it.
Thanks.
Always a good time, JP. As always. Anytime you need me, nephew, I'm here.
Man, I gotta make my way up there. I'm happy to be seeing you come down to Charlotte soon. But I really want to take this moment to highlight the fact that the resident research that's been done across the world for pharmacy residents is something that I think is not as appreciated as much as it should be. And the people that can actually get their papers published, that goes through all of the hardships of a residency year. So I really want to highlight this, and I'm hoping that a few more of the papers that I find are going to be those that publish. But I also want to caveat that there are thousands and thousands of residents out there right now completing research that's going to be answering important questions. So I really want to commend everyone who's doing this research and who's answering important questions, and let you know that if you feel that your paper is going to be super important and you want a place to highlight that, whether it's published or not, the research is answering questions that we should know about. Let me know. And all you guys out there are Pharm So Hard. So thank you, Brock. Thank you, Brian, for coming on. And you guys know I like to close out the episode every single one the same exact way. You don't have to be a pharmacist. You don't have to work in the ED, but everything you do, make sure you Pharm So Hard.
Closes it. Ozzy scratches his head. Whatever she's looking for, it isn't in there.